Good evening, good afternoon, good morning from where you are joining from. Welcome to this LabCoP ECHO session on 5th December 2024. This session will focus on the elimination of mother-to-child transmission of HIV and early infant diagnosis targets experience from Botswana. Please note that the session is translated and you can get into the French or the Portuguese channel. You can put your questions into the chat box as the presentations are ongoing. And then the slides will also be shared at the end of the session. So globally, an estimated 1.3 million women and girls living with HIV become pregnant each year. Transmission of HIV from a mother living with HIV to a child during pregnancy, labor, delivery, or breastfeeding ranges from 15 to 45% if no interventions are provided. Elimination of mother-to-child transmission of HIV is strongly supported by global commitments and the promotion of integrated interventions into maternal, newborn, child, and adolescent health services, as well as strengthened health systems. WHO and other agencies continue to work in this area, supporting countries to improve and better monitor interventions towards ending the AIDS epidemic as a public health threat by 2030. So this area is also important for LabCoP because we have seen certain gaps in the countries that we support. And I'll briefly tell you about the status of elimination of mother-to-child transmission among LabCoP countries before we go into the main presentation. So as LabCoP, we did a survey among 13 African countries to look at the policy landscape and to see if all the issues are covered. So one, all the 13 countries had policies that entail prevention of mother-to-child transmission guidelines. All those guidelines addressed testing of pregnant mothers. There was follow-up testing after delivery for both the mother and the infant, and also during breastfeeding. There are also opt-in or opt-out of HIV testing that is addressed in these policies. All the 13 countries also had EID algorithms well-defined within them, and also PCR testing of children below 18 months, and also initiation of treatment post-initial positive NAT result, and also serological assay for children older than 18 months. The only gap was in implementation of an indeterminate range. And then there were program reports on vertical transmission, but there was a gap in terms of differentiating infection during breastfeeding or intrapartum. And then there were also laws that govern the right to healthcare. We went ahead to conduct self-assessment in 24 LabCoP countries using a WHO Afro EID tool that looks at the cascade for EID, ranging from coordination by laboratory directorate all the way to data management and the use of results. And through this survey, we identified several gaps. So here we use the capability maturation model that ranges from red, which means there's nothing in place, and it goes up to green, which is the standard that we need to reach. So as you can see, very few countries in terms of procurement of reagents and commodities were able to score green. And so there were a lot of stockouts within the last 6 months by the time this survey was done. The other low indicator was in terms of turnaround time of results, usually more than 15 days, even though there were testing capacity sufficient within these LabCoP countries. The other gap was in terms of receiving results by the caregivers within 30 days. So less than 75% of results were actually received within 30 days. The other gap was in terms of quality management systems implementation in the laboratories that are conducting early infant diagnosis. So this could compromise accuracy of results. And then the other one was testing infants within 2 months. So the target should be greater than 80%, but many countries were struggling to even reach that 80%. We went ahead to look at data from UNICEF 2023. So this data is publicly available. And here is a graph of countries. So each bar represents a country and a target of 95% for pregnant women presenting at ANC who test for HIV or know their status. So we can see high figures among many countries showing that at least PMTCT program is working, but there were some countries that were lagging behind, the ones in red. And then when we look at the percentage of pregnant women living with HIV who are on effective ARVs for PMTCT, yeah, so again, there are countries that are doing very well, that are meeting the 95% targets, but there are some that are still yet to meet that target. When we look at testing within 2 months, this is where we had the greatest gap, and only Namibia and South Africa were reaching that target, and Botswana was just about there. And then in terms of estimated mother-to-child transmission, the target is to be 5% or less towards elimination, and only 4 countries, Namibia, Eswatini, South Africa, and Botswana, were able to meet this target. There were still significant gaps in terms of putting infants on treatment, and this needs to be addressed. So as a community of practice, what can we do? So one is to invite those countries that are meeting the targets to share best practices. So like today, Botswana will share their journey towards meeting some of these targets. We need to address the issues of equipment maintenance and also procurement and supply of commodities. And we have started to collaborate with the USAID and Chemonics to start a number of eco series that have been ongoing. We need also to ensure that we involve the community in addressing some of these gaps. So can the communities also conduct community-led monitoring, and also to identify issues that affect the communities that need to be incorporated even as we develop interventions. And lastly, can we integrate and also do diagnostic network optimization to support or reduce the turnaround times, the long turnaround times that we are seeing for EID, as early treatment is equated to better outcomes for infants. So today, we are inviting Queen. Queen Ntusang is a PMTCT National Master Trainer and Program Officer in the Ministry of Health, Botswana. Melabogo Queen Ntusang is an experienced nurse midwife, having started her career in 1998. With over 25 years of service in public health, she has specialized in HIV programs, particularly in prevention of mother-to-child transmission of HIV. As a national master trainer and program officer at Botswana's Ministry of Health, Queen has been pivotal in training healthcare professionals in HIV testing services and PMTCT programs since 2004. She holds a master's degree in nursing science from Burapha University, Thailand, and a bachelor's degree from the University of South Africa. Her dedication to maternal and child health, coupled with her expertise in HIV management, has significantly contributed to Botswana's PMTCT success and the country's attainment of the WHO silver tier. So welcome, Queen, and you will tell us what this WHO silver tier is and your journey towards meeting this target. Thank you.
Thank you. I'm going to be sharing with you the how we achieved elimination of mother-to-child transmission of HIV and early infant diagnosis targets. The outline of my presentation is the Botswana PMTCT program, Botswana's experience, that is path to elimination, validation, the EID processes in Botswana, challenges and EID mitigation strategies. That is Botswana is in the southern part of Africa, and we have a population of about 2.35 million people. And we are challenged because we have an adult HIV prevalence that is high, almost around the whole country, the world. And the prevalence around adults between 15 to 49 was 16.59 using Spectrum 2023 reports. And the estimated number of people living with HIV still using the Spectrum 2023 report was 360,000. Despite those high numbers that we have of people living with HIV, we are not discouraged at PMTCT. We have a goal that is to eliminate new pediatric HIV infection and improve maternal, newborn, and child survival and health in the context of HIV. And we want to achieve this while we have this objective that every woman that is tested and tested positive, we should initiate them on treatment. Hence, that's how we can manage to achieve our goal. And given the numbers that we have for 2023, we had 47,260 deliveries, and amongst this, using the prevalence of 17.2%, we will estimate that we have around 8,000 women who are HIV positive by the time they are delivering. And with that, with no interventions of PMTCT, that means we can end up with around 2,845 babies to 3,252 babies that are born HIV positive every year. But with our PMTCT intervention, taking the program data for 2023, we managed to have only 38 babies that are positive, that is 0.45%. And this is how we have been faring throughout the years with our PMTCT programs, with the interventions that we have been doing. Mostly that is testing every woman that is pregnant coming to the facility and initiating those that test to be positive on treatment, and then hence achieving those low MTCT rates. Like I've said previously, for 2023, our testing rate was 98% and our treatment uptake was 98 and our MTCT was 0.45. After achieving all those, we were also evaluated by the WHO. Actually, after seeing that trend that we have, WHO made us to assess ourselves to see if we can be validated for elimination. So we assessed ourselves and we sent the report and they came to us, they assessed our report. And in 2021, we were able to be given a silver tier for having been able to eliminate the transmission of the virus from the mother to the baby. And the assessment that were done, they were looking at indicators. We had process indicators and impact indicators. For process indicators, they were looking at antenatal care, that we should be having a coverage of more than 90% of women that are coming to register. So in 2019, the year that we were assessed to be given the silver tier, we were at 93.9%. And right now by 2023, we are at 97%. The other process indicator was for coverage of HIV testing for pregnant women. We were also expected to achieve more than 90%. So for 2019, we managed to achieve 94.1%, and for 2023, we achieved 98%. The other indicator there was for treatment. My slide is down, but for treatment, we also managed to achieve, it's 90, I think there is 92% for 2019. Unfortunately, my slide always has gone down. I cannot see from this side. Then for impact indicator, for transmission of HIV, we are a breastfeeding population that we were expected to achieve less than 5% of mother-to-child transmission. And for 2019, we were at 1.9%. And for 2023, we are at 1.17. And for case identification for 2019, we were at 426. All this achievement made us to achieve that silver tier. Together with that achievement of the silver tier, there's another thing that we are doing well in our country. We managed to attain the targets for UNAIDS. That is the 95% that was set by UNAIDS by 2021. We had a bias survey that identified that we are at 95% of case identification. That is for people that are living with HIV. 95% of them were able to know that they are infected. And from them, 98% of them were initiated on treatment. And from those that were initiated on treatment, 98% of them were virally suppressed. That is one of the achievements that we made to achieve for 2021. So how do we manage to achieve all this, the silver tier and the targets? We are mostly using a comprehensive approach to PMTCT, that is using the pillars that have been given by WHO. And the first pillar that we are doing is the primary prevention of infection and vertical transmission. This is where we test either pregnant or not pregnant. Every woman that is in the childbearing age is tested. That is our target in that pillar. And the essential services that are provided there is that routine testing for every pregnant woman. We'll also give treatment to anyone that is tested positive, and preventive measures to those that are tested and they test negative. Our preventive measures go up to giving PrEP to those that are assessed and be found to be at risk of acquiring infection. Then we go to pillar 2. In pillar 2, that's where we address sexual and reproductive health, linkages, and integration. In this pillar, the services, the target population there is pregnant and is women who are living with HIV. These women, we don't want them to fall pregnant unaware or have unintended pregnancies. So they are counseled on when they can become pregnant. They are given contraceptives to monitor their viral load so that by the time they decide to get pregnant, it is at that stage that they cannot transmit the virus to their children. The other counseling is for those that are found to be having partners. Maybe there is a couple that the mother is, the woman is negative and the man is positive. There, the woman is also given preventive measures like always using condom or monitoring the viral load of the men so that by the time they also decide to have a baby, the viral load of the men is suppressed so that they cannot transmit the virus to the mother, and the mother is also put on PrEP. Then going to pillar 3, which targets pregnant and breastfeeding women who are already HIV positive at the time of them being tested. Here we give lifelong treatment to these mothers from the time that they are found to be positive until, I may say until they die or what, but that's a lifelong treatment to the pregnant women and breastfeeding women, together with monitoring their viral load, because we know that if a woman has a high viral load, the chances of transmission is high. So their viral load is monitored every 3 months. And for those who are found to have not been virally suppressed, their viral load is monitored every month until they are virally suppressed. The other thing is that they are also encouraged to do routine antenatal, and they are encouraged also to come for postpartum, for postnatal care. The last pillar there is infant and child and partner services. In this pillar, we target the HIV exposed babies, the partners of this pregnant or breastfeeding women. There, the services that we provide is testing for these exposed babies. They are tested at different intervals, starting with we have introduced a new test that now we will testing them at birth. The other test is done at 6 weeks. The other test will be done at 9 months. And the last test will be done at 18 months to now know the final outcome of these babies who have been exposed to HIV. And with partners, they are encouraged also to test if they are found not to be infected, or if they are found to be infected, they're also put on treatment. The other thing with the babies there is that for a mother who cannot breastfeed, let's say they have a viral load that is not suppressed, the babies are given formula for a period of 1 year. And for those who are virally suppressed, they're encouraged to breastfeed, and that is for the first 6 months. And after that, they can opt to now get the formula for the last 6 months of their baby's life. The other thing that we are doing is community interventions. In community, we have community healthcare workers that are mostly coming through civil societies, which aim at combating stigma, support adherence, and improve understanding of HIV, maternal health, and the importance of maintaining undetectable viral load. They also do home-based ART adherence counseling, mobile reminders, and regular check-ins, provide personalized support to HIV-positive mothers. All these elements are essential for viral load, hence leading to EMTCT. Some of the milestones that we managed, that we are made us to be able to be successful are that we have a strong political will. Our government supports us, and we also have the strong support of the international partners. We also have this capacity and rapid adaptation to new protocol. Every time when WHO has new guidelines to be reviewed or to be adopted by countries, we are always at head to adopt those guidelines. And after adopting them, we train our healthcare workers so that they can go along with new protocols. We are also fast in adopting new treatment according to the recommendations of either of researchers or from WHO. And we are also doing free ARVs to non-citizens. For everybody in Botswana that is HIV positive, whether she's a Botswana or not Botswana, she's given treatment, ARV treatment free. The other thing that make us succeed is engagement of district health management teams and the CSOs. We know that from the ministry, we cannot run things on our own. So we decentralize things to the district. You'll find that these trainings that we do, we are not doing them centrally. They are at times conducted by the PMTCT TOTs in the district with the support from the ministry. And we also have strong CSOs that are also doing that, like I was saying, they have community healthcare workers that we train and they go out to help us cascade or help us disseminate the messages of PMTCT. We also do the capacity building of healthcare workers in relation to human rights and gender equality. We work hand in hand with our organizations like Bonella, which are working with people living with HIV and human rights. They help us to do all these trainings. In the district, we also have the PMTCT focal persons, the community healthcare workers, counselors that are always resourced, and they are very active in disseminating information and seeing that the PMTCT program runs smoothly in their district. We also do follow-ups by these counselors, the PMTCT counselors, together with the community health care workers. They follow up mothers that don't turn up for CWC or the mothers that don't bring their babies for testing. We use these counselors and we use the community health care workers. Then the monitoring of viral load, like I said, is done every 3 months for pregnant and breastfeeding women. You'll see that our tests, our viral load tests are done in all the labs that we have in our country. And the specimens are collected in every facility in our country. And these specimens are transported to the labs using our ambulances. And from the district labs, if they need to send samples to bigger labs, they always use couriers to send specimens to those labs. Challenges that we face while implementing the PMTCT. We have low partner involvement, and we have since tried to engage, to change our strategy, to do now active partner follow-ups for testing. Here we want to get a permission from the mother to call the partner at the time that the mother has come for testing or come for registration. If she didn't come with the partner, we are intending now to make calls to this partner with the permission of the women and seeing how they relate with their partners, so that we avoid intimate gender violence. We also have a challenge of seroconversion for pregnant and breastfeeding women. This is where our women, they will register from ANC. Let's say the first initiation, they register, they are negative. But along their pregnancy, when they are tested, they test positive. Or during breastfeeding period, they test positive. This is also a challenge because at the time that a woman tests positive, the chances of transmitting the virus to the baby is high. And from our statistics, we have found out that most of our babies that turn out to be HIV positive are from these women who either have tested positive during pregnancy or they've tested positive during breastfeeding time. So we are also trying to combat this by introducing PrEP, offering PrEP to all mothers that we test and test negative. We assess them for any risk behaviors that they might be encountering. And if someone cites that they are at risk, they are started on PrEP. They also encourage them to do safe sex, that is using condom and using it consistently. The other thing that is challenging is suboptimal utilization of EMR. For us to have good results or have good data, there have to be utilization of EMR, because without that, we will not have a very good statistics. So we are doing that now to try to mitigate that problem. We are doing capacity building for all our healthcare workers and doing mentoring and support, going out there to the district to try to support them to utilize EMR. With that now, I will move to early infant diagnosis, how we are testing our babies that are HIV exposed. I don't know if I should pause for questions or I should continue, Collins. What's your take?
No, just proceed. We'll have questions at the end.
Okay, thank you, sir. So in this presentation, we'll look at the goals and background of baby testing, the pilot that we did before we started the baby testing, the importance of early infant diagnosis, the technical background and infant testing. The goals of EID, HIV-infected babies can be identified from birth to 8 weeks of age before they become sick. Those that test positive, they can be started on treatment after confirming their HIV infection, irrespective of clinical or immunological status, to reduce pediatric mortality and morbidity. It provides feedback to the Ministry of Health on the effectiveness of the PMTCT program. EID, it refers to the process of testing infants who are HIV exposed, typically from birth to 8 weeks. The primary goal of EID is to identify infants who may have been infected with the virus during pregnancy, childbirth, and breastfeeding. Since inception of PMTCT, there were no proper guidelines on baby testing before 18 months. There was little to no understanding of the impact of the program. No feedback was given to mothers for their efforts on adhering to their PMTCT program. And there was a poor testing coverage at 18 months. You'll see that when we started with PMTCT, we were just waiting for the baby to come and test her at 18 months, which was not giving us a clear picture of what is happening. And at 18 months, you'll find that most of the babies are no longer staying with their mothers. So testing there was a challenge. So why do we need to test the babies? PMTCT interventions reduces risk of MTCT, but even with ARVs, some infants will acquire the virus from their mother. The HIV-infected infants are at risk for disease progression. You see that in the baby that is HIV positive, the disease progresses very quickly. And if they are not put on treatment, around 1/3 of them can die within a year, and half of them can die within 2 years. And CD4 and viral load are poor predictors of disease progression in infants. We did a pilot in our country in 2005, that is from June to December, in our 2 big cities. The other cities in the southern region and the other cities in the northern region. During the pilot, 250 nurses were trained, nurses and doctors and lab technicians, midwives, they were trained on collection of the DBS sample. The dry blood spots were collected to solve the storage, transportation, and blood collection problem and allow wide access to early diagnosis. The objective of the pilot was to determine feasibility of DBS collection at government clinics during routine infant care, that is during CWC time. Identify and solve problem with sample collection. First, you'll find that collecting a specimen from a child was a very difficult procedure to do. You will not be able to fill that small EDT tube by collecting the blood from the baby. It will mostly have to be done by doctors or done by the lab technicians, and they were not there in all our facilities. So we had to train those people that are there in all our facilities so that we improve the coverage of our baby testing. Using of the training on DBS also was to establish quality assurance system at the lab, show rates of HIV infection among infants, and track infant diagnosis early to determine if early diagnosis leads to early treatment. From the pilots, it was found that it was very successful. The results show that PMTCT program is quite effective with very low rates of infection among infants who received PMTCT interventions. DBS worked well, and collection was easily integrated into routine infant care in the clinics. Nurses and midwives equally succeeded at collecting the DBS sample. The biggest laboratory problem was labeling. That was identified was labeling of the specimen. It was important to have correct information in all the documents. Then the recommendation after this pilot was for the Ministry of Health to roll out this DBS collection to all the facility in our country. Who was eligible for this early diagnosis? All infants born from HIV positive mothers should be tested. Well, like I said from the first slides, I said we introduced a birth test. So our babies will be tested at birth. The others that were missed can be tested between birth and 6 weeks. And mostly the birth test, we are going to be doing it for high-risk babies that at the time of delivery, they are identified to be at high risk of having acquired the infection. And those who are tested and test positive, they will immediately collect sample for confirmatory and refer them for treatment. Those negative with the first test or with the test at 6 weeks, they will be tested again at 9 months. And those testing negative at 9 months, they will be tested again at 18 months, now with a rapid test. In between all these tests, if a baby can become sick, even though she has tested negative previously, the baby will be tested. Those that will be tested before 18 months will be using the DNA PCR, and those tested after 18 months will be using the rapid test. Breastfeeding women, breastfeeding babies will be tested again 6 weeks after their last breast milk. That is for babies that will be breastfed up to maybe 17 months before they are 18, or at any time that they are tested before they are 18 months, they will be tested with DNA PCR. That will be 6 weeks from the last breast milk. And if any baby can be breastfed above 18 months, that child that is after stopping breastfeeding will be tested using a rapid test. All infants are started on ART immediately without waiting for confirmatory tests if the baby's results come back positive. The trend of our testing, this is the EID, the test that we do from birth to 6 weeks, or I can say from birth to 2 months. That is the trend that we have been having. We are doing well, but not that much doing well, because as you know, mostly the targets have to be 95%. But you will see that for 2023, we were at 86% of our EID, and 2022, we were at 80%. But all in all, when it comes to baby testing now is, here we are saying the initial test that we do, you'll find that we are not doing well, yes, with the early that is up to 2 months, but from 2 months, we managed to get the babies to test them. So with the first test for 2002, we managed to test the 95% of the babies. And for 2003, we managed to test 98% of those babies that are exposed. And with treatment, we are also doing well with initiating our babies on treatment. This is using the program data. I know that from Colin's report, you saw that we are at around 65% of treatment, of initiation of treatment. But this one we are using from Colin's presentation, that is using our spectrum, that is our estimates. They are using estimates, but here using our program data. We had for 2023, we were at 100%. All our babies that were tested positive, we initiated them on treatment. And for 2022, we were at 91%. When you go back to collecting the DBS specimen, like I said from previously, this specimen is collected by nurses, it's collected by lab technicians, it's collected by doctors. So we find that we are able to do this in every facility in our country. These are not the only healthcare workers that are involved in this DBS sample collection. We have peer mothers and healthcare educators that educate and inform community and families on infant testing, assist with follow-ups of HIV-exposed babies. In our facilities, we have cleaners. These cleaners are also trained on this DBS. Their part is that when the specimen is collected and is kept where it's while awaiting to be transported to dry, they should know how to keep the environment around the specimen safe. They should not throw it away, seeing that it's blood on a paper and thinking that maybe the nurse has forgotten about it. There are other workers there. We have the healthcare assistant and the social workers. They also provide pre-test information and post-test counseling and support follow-ups of HIV-exposed babies. Drivers are also trained on this DBS because they have a role to play as they need to transport this specimens safely to the next lab. Then the specimen transportation cascade, the DBS specimen follow the same pathway as other blood specimen tested in HIV and reference and all laboratories. All specimens are captured on IPMS and are available electronically at connected facilities. Otherwise, hand copies are printed and dispatched to facilities. So our specimen will find that they come from clinics, from health posts, they go to the lab, from the local lab. If that local lab is not performing EID, is then transported to the reference lab. So in between the health post and the local lab, we use ambulances, and in between the local lab and the EID testing lab or the reference lab, we use couriers at most of the time. After testing the babies or after having these babies that are HIV exposed, we are able to track them because we have this register that we call the National Birth Cohort Register. Healthcare workers are trained, and in between trainings, they are mentorship for them to be able to fill this register so that we track our babies and be able to evaluate either we are doing well or not doing well. From those pictures, you'll find that the picture on the left is the PMTCT focal person mentoring the healthcare workers on the use of the cohort register. From the right side is the PMTCT, our PMTCT MNE officer from the Ministry of Health training healthcare workers on the use of the cohort register. So I've been trained on the use of this cohort register. We also have a reporting tool that we use to capture our reports monthly. We have all those variables that we are capturing every month, and they are reported to the national office, and the national office can then now at the end of the year know how many babies were exposed and how many babies were tested and how many babies were positive. Management of missing and delayed results. It is important that every infant tested be given their results within an appropriate period. So the turnaround time from sample collection to share with the results with the client is urgent for a sick baby. So we mostly can get it within 5 days. And routinely, we get it within 28 days. And for a baby that is HIV positive, mostly the labs, they will call the facility to inform them that we received your specimen and we tested and it has tested positive. That makes the mother to be followed quickly and the baby to be started on treatment early. Those are some of the management that we do to try when we are having missing results. So the facility will write a tracking form and send to the lab, and from the local lab, they will then send that form to the referral lab, which in return will also check the results and return them back to the facility. And in case the results are not received within 28 days, there is a redraw of blood when caregiver returns with the infant or retesting of DNA tests. The challenges, like I said, we have low coverage of EID. Some of the mitigating strategies that we are doing is try to implement the one-stop shop, where when the mother has come for immunization or we have come for CWC every month, we review the card to try to identify if this child needs to be tested during that visit. This also, we have also do the scaling up of EMR in PMTCT service delivery, that is in SRH, maternity, and CWC to track our infant. Strengthen facility community interface to support PMTCT. Like I told you previously, we have community healthcare workers that are mostly supported by our CSOs. We use them to interact with the community. We also have that register that I talked about, the birth cohort register, that we use to track our babies from birth up to 18 months or up to 24 months. We We also have introduced a birth test for high-risk babies. We also do capacity building for healthcare workers. We do mentorship and support visit. We use EID champions and mentor mothers to try to follow up these babies. With EID champions, they are placed in some of the high volume facilities. We use them to follow up mothers that are not turning up for their babies to be tested. And the mentor mothers are in some high volume maternities. They start with the mother from delivery up to the time that the mother have managed to bring the baby up to the 18 months test. We also have a challenge of high turnaround time or late diagnosis. Here, we are still in talks. We haven't yet started. We are thinking of introducing point of care that can solve the problem of long turnaround time, especially in far and hard to reach places. Although Botswana has rolled out tests to large district laboratory across the country, which saw the program performance peaking at the turnaround time, the country now faces an end of life of some testers, some analyzers, which strengthened the program's exceptional performance as we only now have 2 referral labs that are performing the test countrywide. In conclusion, through a combination of universal access to ART, integration of health services, decentralized care, task shifting, and community engagement, Botswana has successfully achieved elimination of vertical transmission of HIV and now work on triple elimination of HIV, syphilis, and hepatitis. You know, I've been speaking about HIV, but now we are bringing along syphilis and hepatitis because they are also the 2 diseases that can be transmitted from the mother to the child. The country's strong political commitment and continuous monitoring and strategic partnership has enforced its success, setting a model for other countries to strive for EMTCT. Thank you. That's the end of my presentation.
Yeah, thanks, Queen. That's a very comprehensive presentation. Yeah, so what strikes me is what you say, the comprehensive approach to PMTCT, and you have described the 4 key pillars there. So the take-home message is that we need to strengthen both PMTCT and EID. So there are a number of questions that are coming into the chat. I think the most glaring one is the use of ambulances for transporting specimen. So Mariamo is asking, is there a risk to the patients in the facilities when the ambulance has been used to transport specimen and might be needed for an emergency? So maybe you can respond to that.
Okay, like I said, PBS is a very safe, what can I say? It can be stored for a long time or about 7 days in a facility. So in case we transport them mostly when we have referrals. It's only when maybe on Fridays when we have seen that we don't have any referrals on that day that the specimen can be taken and be transported to the next referring facility. And mostly you'll find that they will be using in a catchment area where they will be having maybe 2 or 3 vehicles. One will be used for transporting specimens, not all of them. Only one ambulance will go so that others will remain to transport in cases of emergencies. Thank you.
Thank you so much. So Flata Mwale says, appreciate the inclusion of CSOs. They play a critical role in closing gaps. So that's a comment. And my follow-up question to that is how you were able to ensure that even those pregnant women who are within the community and do not come to the health facilities are actually reached. So you said 90%. So how do you ensure that this happens?
I said we use community health care workers that are mostly based in through our CSOs. We also have in facilities. We also have healthcare assistants that we are using to follow these mothers. And you'll find that in our country, most of our villages, they have healthcare clinic, they're either clinics or health posts. So even in a small village, there is the health post, and you find that there are not many people. Remember, our population is 2.3 million. So we are not that many that will miss a pregnant woman in a village. Those who are at the farms or at the field, there are facilities that are doing mobile clinics. They visit those lands or they visit those cattle posts, either monthly or quarterly, depending on the transport situation in that catchment area. So mostly our mothers are reached, and most of our mothers, they deliver in the facilities.
Okay, that's well noted. The other question is, you mentioned additional testing time points for EAD. So you've included birth and a test also at 9 months, but you also say that when a child is sick, we need to confirm whether they're infected if they were not tested, or they were tested before but they were negative. You still need to do another test. So what informed your modification of the algorithm, and what are you seeing after modification? Are there additional benefits that maybe other countries can learn from?
What informed our modification was the recommendation from WHO. And the other thing that informed us was that we have high-risk babies that we want to capture early, to test early. Like I was saying, our birth test is done for high-risk babies. So we really want to save this baby as early as possible. Then the 9 months test, we do it so that we close the gap. Like I was saying, at 18 months, most of the babies are no longer staying with their mothers. So we'll find that we were testing at 6 weeks, then the next test was at 18 months, which is now a very long gap to know the outcome of this baby, to know the well-being of this baby. So when WHO introduced the 9 months test, we ran for it, grabbed it, so that it also helps us to close this gap. It's a new thing that we are starting, and we are going to be starting it this year. We are still developing the guidelines for us to start it. My co-presenter, Elder Linto, has raised her hand. Maybe she wants to help me answer some of the questions.
Okay, Elder, please go ahead.
Yes, please. Thank you. Thank you so much. I just wanted to add on the issue of what really motivated us to start the birth testing. Like Queen has said, we really wanted to identify the babies who are HIV, who got infected in utero as early as possible. And this was after the study that was conducted by our Botswana Harvard partnership. We have a collaboration with Botswana Harvard partnership, who are doing most of the studies in relation to PMTCT. They did the study, and it helped us to see that it's feasible and it's important that we can do that using the birth testing. Thank you.
Thank you for the addition. So there's also a question about return of results. So Muluken is asking if you have an electronic system that you can use to return results that may help in terms of shortening turnaround time. If not, have you considered having this in place?
Yes, we have the IPMS. The IPMS, like I was saying, every test is captured in the IPMS, and the facility that is connected, they are able to get these results as early as maybe 2 days after test or after it has been captured. So now to facilities that they don't have this, because it's mostly in in hospitals and in some big clinics. And you'll find that in health posts, it's not there. So then now in those health posts that they don't have this PIMS module, they go to the next facility. There are mother clinics. There are those that we call mother clinics and health posts. So they can print their results from these mother clinics.
Okay, thanks. So what does IPMS stand for? Hello? Yeah, Elder, you can answer.
Integrated.
Yes, I just wanted to emphasize the issue of HIV positive babies, reducing turnaround time among infants who are HIV positive, like Queen's presentation has alluded to. As soon as the baby is HIV positive, the lab will call the facility to say the baby is HIV positive. Then the baby will be followed up and be initiated on treatment. And then the other thing, the lab has really tried to decentralize the lab module. Sorry, can I continue?
There's some interference. Fitsum, deal with it.
Yes.
Okay, please continue.
Yes, I just wanted to indicate that there's you find that our facilities, they don't have the labs. Not all of them, I mean the smaller facilities, but the lab has decentralized the lab module so that the facility can get the results from IPMS. That's
okay.
Yes, it's an electronic system whereby after the lab has tested, then someone at the facility can access the results. That's one thing that has really helped us in reducing the turnaround time. Thank you. Over.
Okay, so thank you. So I think in the interest of time, we can have two last questions. So
please,
one
you asked about IPMS. It's integrated patient management system. And there's somewhere where I mentioned PIMS. PIMS is patient information management system. And for IPMS is centralized, while the PIMS is in health facilities, it's in even small facilities, and it's not centralized.
All right, thanks for the confirmation. So Gopi is saying a commendable effort by all stakeholders and well presented. So the question is, with your view of a preventative approach, how engaging were the partners of the pregnant women in participating in testing and treatment? And then you can also expound on what you mean by strong political leadership. And then finally, how did you manage the challenges with the commodities? As we saw, that was a common gap across countries. Over.
The first one was with partner. I'll take the partner. Martin will take the leadership and the commodities. With partner, I said is one of the challenges that we are having. We have low partner involvement, but we are really trying. We are doing community activities to try to encourage mothers, the partners to join us, to join their mothers. We do workshops for men in different villages. We do activities for them, like holding football matches and testing them during those football matches. We are really trying, but we are still having a low turnaround time. That's why I was saying low testing rate or low involvement of partners. Thank you, Martin. To take the two.
When it comes to the political will really, we meant that when the program has started, the government made a deliberate decision to actually support it, to prioritize it, and it is fully funded by the Ministry of Health, Government of Botswana. All the strategies, infant feeding strategies, the treatment, everything is funded by the government. So the ministry is always, like in a position to actually fund. They'll always provide funds for the PMTCT program. Even up till now, it's still a priority. Thank you.
Yeah, thank you so much. Queen
Elder
and Elder.
will take.
I think I missed the question on commodities. Sorry
Yes,
about
please
that.
proceed. So please proceed as you say your last comments as well. Queen.
Yeah, thank you very much. I think with the commodities, Mayor Matale, she was the one that was speaking through Elder. I think she tackled it because for all the commodities, we are funded through the government. The government makes sure that we have formula for kids, we have test kits, we have everything that we need is through the government funding, but also with the help of the international partners, like for trainings, the partners are there to help us, and even at times even for buying computers to be used in district, our international partners, they help us in doing that, in attaining all those. Thank you very much, Collins, for this presentation. I think that is that.
All right. Yeah, thanks Team Botswana for sharing and kickstarting this series. We have learned a lot and we look forward to engaging with you to learn some of the best practices, including male involvement in future ECHO sessions. And yeah, we look also forward to you sharing maybe some south-to-south visits with other countries who might want to improve their EID programming. For the rest, please do have a good day, a good night, or a good morning, wherever you are. And we'll be able to share the codes for downloading the certificates in the emails that you have provided. Otherwise, thank you so much and bye.
Bye.